So good evening, everyone who's been able to join us for this another session of HealthTAPE. And today as speaker, we have Dr. Carolyn De Lucia, and she'll be speaking on the topic Advances in Cosmetic Gynaecology and her experience over years. Well, before we move forward with this webinar, may I take this opportunity to briefly introduce IASRM to all of you. For that, I'll be sharing my screen. So IASRM, International Association of Stem Cell and Regenerative Medicine, is the world's leading community for industry specialists, academic institutions, and researchers to learn about the latest researches in stem cell technology, cellular therapy, and regenerative medicine. ISRM is a non-profit and an independent organization that aims to support and raise advancement in stem cell science and its application to human health. And it provides you with an extraordinary community that addresses the key areas of clinical interpretation, academia, regulatory, and commercialization of this promising regenerative medicine field. Well, the vision of ISRM is to make itself the association and authority of training and learning for quality advancement of healthcare with innovative regenerative medicine. And in order to fulfill that vision, we bring you valuable knowledge that is efficient, effective, and respectful for science, medical, and healthcare service with integrity and accountability, using both proven, approved applications, methods, and protocols. And just as a part of that mission, we bring you these episodes of HealthTAPE, where the experts from their own fields, they come up on this common platform and share their experience and their wisdom with you all. Well, we have the board members of ISRM. We have Prabhu Mishra as president, Dr. Cheryl Pollard as secretary general, Dr. Diana Mihai as vice president, Dr. Didam Kurban as joint secretary, and Dr. Nidhi Jha as executive committee member. The ISRM International Scientific Advisory Board consists of national and international experts in regenerative medicine field. And why should you join ISRM? Well, we all know that stem cell based regenerative and cellular medicine is an emerging and exciting area, and every day new technologies and novel approaches are added in this field. So to learn about these advancements, physicians with academic affiliations may look forward to get acquainted with these technologies, and ISRM gives you the opportunity to be able to legitimately practice the regenerative medicine so that you can advance your career as well. So ISRM acts as a platform for learning about the emerging stem cell technologies and ongoing research and education. Well, so who all can join ISRM? ISRM can be joined by anybody who's interested to work in this field of tissue engineering, stem cell, translational medicine, gene and cell-based therapies. It is open to scientists, doctors, researchers, entrepreneurs, companies, and anybody who has the zeal to learn about the emerging novel approach. Well, I would like to now throw some light on the signature courses from ISRM. We have fellowship in stem cell and regenerative medicine. It is a thorough one-year course with 7 days practical training, where you get live demonstration on patients, specialty-wise training. Hands-on training is provided for 7 days, and it is a one-year online training course with the global faculties and experts coming to teach you about the stem cell and regenerative medicine area. So gynecologists, surgeons, orthopedicians, anybody who is willing to learn about this emerging field can enroll themselves into this course, and more information can be found on our website. Well, we have also come up with one of a kind for the first time, a long-term one-year full fellowship program in cosmetic gynecology in association with hospitals, university, and various international organizations. Apart from that, we also have 4 months mini fellowship for cosmetic gynecology. In 1 year, you get 7 days hands-on training, and for 4 months, you get 4 days hands-on training course. And as you can see, the course content revolves around the energy-based devices, the use of PRP, PRF, carboxy, pelvic floor repair, BHRT, surgical procedures, genital fillers, threads, Botox for vaginismus, and the related areas. Also, the hands-on training will be provided in non-invasive form and also through invasive technologies. The third course that we bring to you is one-year fellowship in regenerative and aesthetic dentistry. Through this course, you will learn about dental stem cell banking, tooth bioengineering, PRP and PRF, research and practical elements will be incorporated, demonstrations of regenerative endodontics will be there, role of stem cells in tooth repair and regeneration, and cosmetic and facial techniques. Again, this is a one-year course with practical training, theory plus hands-on training will be provided, one-to-one training is there, scientific sessions are conducted over Zoom, where the international faculties are invited to give talks on certain topics. And if you want more information about any of these courses, please feel free to write to us, email us, or visit the website www.isrmglobal.org. And with this, I would like to stop sharing my screen and invite Dr. Prabhu Mishra to kindly introduce our speaker for today and commence with the webinar.
Thank you, Dr. Nidhi, for this wonderful introduction of the association. Let me introduce, and first of all, would like to formally welcome Dr. Carolyn De Lucia, and she is not only a aesthetic gynecologist, I can say, and later she's a wonderful friend. She is amazing doctor, and a mother and author of the book, like very popular book, Ultimate Intimacy, and amazing human being. This is what I can say. Because in this journey, Dr. Caroline, when we first met in 2015, you remember, so since these days to, yeah, so like many things we learn each other. Dr. Carolyn De Lucia, MD, FSCOG, is a pioneer of at the leading edge of non-invasive sexual wellness treatments, practicing OB/GYN for nearly 30 years and alternative therapy expert since 2014. She is sought after by device manufacturer and professional groups alike. And she's not only like especially for this energy-based devices and the routine, the many advances in regenerative medicine. When I heard like, even beyond the PRP and the post-PRP era, the another era is coming, the exosome therapeutics. And this is what last year, when 2019, Dr. Caroline came to India and presented us about the exosome therapeutics and the development, especially in vaginal atrophy and stress urinary incontinence. It was remarkable work. So she's going to share her journey throughout for this abundant 30 plus years. So welcome you, Dr. Caroline. Yeah.
Thank you so much. Thank you for that wonderful introduction. It's such an honor to always be here and to be associated with your amazing organization and all of these incredible physicians that make up the staff and faculty. So I will share my screen, and no further ado, here we go. So today I'm going to be discussing the field of cosmetic gynecology and where we have come, because back in 2014, it was virtually unheard of. And here we are with Dr. Prabhu having a course that's a fellowship that is available, which is truly amazing. So where did it all begin? Well, as an introduction, I'm Dr. Carolyn De Lucia. I'm a board certified OB/GYN from the United States. I have not practiced obstetrics since 2001, but I am still practicing gynecology.
Hello?
I have, yes?
Yes.
Can you hear me?
Yes.
Okay. I'm faculty for the American Aesthetic Association, the Cellular Medicine Association, Intimate Wellness Institute, and Boston BioLife in the United States. I'm affiliated with Robert Johnson Medical Center in New Jersey. The learning objectives today are to redefine cosmetic gynecology, learn the prevalence of female sexual dysfunction and needs for providers in this space, to learn the value of procedures available to address concerns, and to learn the financial benefit of providing these treatments. I have no disclosures with commercial interests in this lecture. So what happened with me is in 2001, still doing obstetrics, I realized that I wasn't being a very good mother. I was away from home quite a bit doing deliveries. I was much more of a midwife than a doctor. I was with my patients from the very beginning of labor all the way through. And I was missing things that were happening with my own children. And my daughter was going to be in a piano recital, and I had coverage for that delivery. I knew she had this event, and I was not going to miss it. But I had a woman in labor. She was 8 centimeters. I put on my superwoman cape, and I was going to do it all. I was going to be at the concert. I was going to do this delivery. And my very, very wise 10-year-old daughter said to me, "Mommy, if you're not in that audience, I am not getting on stage to do my piano recital." And I said, "Of course I'm going to be there." I missed it by 5 minutes, and she did not get on stage. And that was really, you could imagine being a parent. So I just said, you know what? These are sacrifices I'm choosing to make that are affecting my family. What can I do to make a difference, but still be involved with my patients and give them what they need? So I gave up obstetrics and focused on gynecology, and ended up being very fortunate to have a young rep from a laser company prance into my office, Mr. GQ. He thought he was so handsome. He was handsome. He is handsome. But he walks in and he said, "I have a laser that rejuvenates the vagina." And my response was, "Turn around and don't let the door hit you in the butt. Get out of my office." And he said, no, please listen. This machine can treat urinary incontinence." And I said, "What did you just say?" And he said, "It can treat urinary incontinence." And I said, "Well, now you're speaking my language. Let's talk about what this can do." And I then bought the very first vaginal laser in the Northeast of the United States. There was one in California and one in Miami. And that laser changed GYN for me and many, many women's lives. And I was fortunate enough to introduce that laser in India. I think it was 2017 when this laser first came to India. And I was there for that, which was a wonderful treat. So subsequently, this field has evolved, and there's so much more involved. We have to understand the importance of intimacy and intimate health in our lives. So as humans with COVID, you have to have become aware of the significance of human touch, not being able to hug those we love during this pandemic has truly brought this issue to the forefront of significance of being intimate as humans. And in a relationship, when there's an issue not allowing a couple to be intimate, it starts to cause trouble and put a wedge between the couple, and that relationship begins to suffer. Let's talk about the prevalence of female sexual dysfunction. The rates of female sexual dysfunction in premenopausal women exceeds 30%. The rates of sexual dysfunction in postmenopausal exceeds 50%. And the rate of sexual dysfunction in women with urogynecological issues, meaning with urinary incontinence, exceeds 60%. Rates of sexual dysfunction in women treated for breast cancer is 60 to 70%, which is similar to other female cancers as well. And the rates of dissatisfied with appearance and anatomy is greater than 50%. Women are extremely self-conscious of their intimate area because they have been shamed by it over just cultural issues where they're not supposed to look at it, not supposed to touch, not supposed to enjoy intimacy. And all of that has made it very taboo. And over 50% of women have dissatisfaction with their own confidence and appearance. So it pays a heavy toll on relationships and the intimate connection. Sexual dysfunction issues then, why did this freeze? My slides froze.
Just a minute.
Let's see.
Can you change to the full screen?
There it is.
Yeah.
There it is. Okay. The impact of sexual dysfunction on quality of life and relationships is immeasurable, underreported, and greatly undertreated. The feminine health concerns that start to evolve in a woman's life following childbirth is some weakness of the walls. Before a woman has a baby, the vagina is like a cylinder. It's a tunnel, round. After a baby, it turns into a square where the walls start falling in from all four sides. Weakness of the bladder, weakness of the rectum, and the side walls can become lax. When this occurs, there's a lack of friction with intimacy and lack of sensation. And of course, incontinence, urinary stress incontinence, frequency, and urgency. 30% of women suffer from stress urinary incontinence issues, and more than 50% suffer from genitourinary syndrome of menopause. And a third of women over the age of 40 will suffer with some form of intimate issue, and over 50% over 65 have pelvic concerns. One of the areas I want to concentrate on is the anatomy of the clitoris. And what we want to point out is that the clitoris is much more than just the glands that's visible upon exam. Behind there is a complete analogous structure to the male penis, having two crura, and that is the corpus cavernosus of the clitoris, as well as the same area of the penis. And there's the vestibular bulbs that play a role. The Skene's glands are also of significance. So what happens as time goes by? The vagina is mainly for procreative purposes. And again, that weakness of that pelvic floor begins to have changes in laxity and loss of sensation. The mons pubis over time will enlarge with fat, and the labia majora lose fat and become lax and loose in the skin. And that affects women's confidence. The estrogen levels drop, and then there is vaginal dryness and painful intimacy. The definition of vaginal rejuvenation is that the vaginal rejuvenation was truly surgical procedures that were started back more than 15 years ago by Dr. Matlock in California, bringing it to the forefront. And it was a procedure that involved minimizing the size of the labia minora, decreasing the size of the labia majora, and also the tightening of the hymenal area, making it a vaginoplasty. And also there then came the non-invasive procedures like the vaginal laser, and they all got lumped together into the definition of vaginal rejuvenation. And then came regenerative procedures and radio frequency. And because they were procedures and machinery that were used in cosmetic procedures, it became vaginal rejuvenation and cosmetic gynecology. And that's how the definitions evolved. But we are much more interested to try to get the definition to be restorative or functional gynecology, because it's truly not about aesthetics, even when we are minimizing the minora or filling up the labia majora. It's still about function. And there's also nothing wrong with women's confidence levels, but again, it's their psychological function that's being treated in that realm of improving its appearance. So starting with loss of sensation, it can happen postpartum, post-injury, hormonal changes, and menopause. Oh, I'm sorry. My dog is participating. So PRP vaginal injections are wonderfully effective. And this is obviously platelet-rich plasma is the portion of our blood that has all the growth factors that improve the collagen and the amount of blood flow to the vaginal wall, the clitoris, and the G-spot zone. And in doing so is greatly improving sensation for intimate purposes. And exosomes here in the United States, much to our dismay, this week, yesterday, as a matter of fact, new laws came into effect that now control our ability to use exosomes. We are not allowed to use exosomes unless the exosome that we are using is involved in an FDA approved IRB study or in an IND with the FDA. These are very strict rules. And the interesting twist is even if the exosome is involved in one of these studies, until it is approved for its IND through the IRB study, it is not permitted to be used in any other function, nor is it able to be used off label. If you are using exosomes off label in the United States, you can go to jail or be fined over $500,000. All of these rules go for stem cells as well at the moment. And that is as of yesterday. So critical changes, but we still have hopes, and we know internationally that they can be used. And I encourage you to do so, because they can certainly supplement and add to the results. So in that regard, using one ml of exosomes to 9 mLs of PRP is a wonderful addition to any of the procedures involved. So we understand for women that, and in gentlemen as well, that the orgasmic system is not simply psychological, but involves the endocrine, neurological, and anatomical, mechanical, as well as the psychological system. The PRP injections into the genitalia can really make a difference. And this is an article that a patient wrote that went viral about the intensity of her response. And the significance is that she was 36 years old and was on antidepressants affecting her ability to be intimate. And the PRP was able to return her to function. So what results we can have from using PRP are greater arousal, a higher, tighter tissues in the introitus, increased arousal of the G-spot area, pinker, younger skin. The skin truly is improved in the vulvar area, and by indirectly improving sensation, it increases desire or libido. It does improve the ability to have a vaginal orgasm. However, I warn you, never, never, never promise a vaginal orgasm, as that is the perfect storm. Everything comes together rather. Ideally, it's extremely rare for women to have vaginal orgasms on a regular basis, less than 20%. So decreased pain as well can occur by using the PRP, and a natural lubrication, as well as improvement in urinary incontinence. We are seeing some improvement with interstitial cystitis as well. So at present, the treatments for urinary incontinence on the market are surgical, still doing anterior and posterior repairs, urethral slings, the perinorrhaphy and the labiaplasties are being used. The minimally invasive procedures are lasers, which can be CO2 or erbium YAG and DYAG. There's now solid state lasers coming to the market, radio frequency. There are injectable agents, collagen and hyaluronic acid, as well as PRP and exosomes. And the non-surgical are pessaries and pelvic muscle training, Kegel exercises, biofeedback, and electrical stimulation. And thank the Lord, HiFem has come to the forefront as being high intensity focused electromagnetic energy in chairs where women can simply sit on the device and have reinforcement and development of their entire pelvic floor. So the prevalence of urinary incontinence as we go through life is extremely significant and increases with living longer, which is happening as we continue to improve our ability to prolong our lives. So lasers and radio frequency are energy-based devices that have come to the forefront with this entire area, and really was the beginning of it all. And they do require a series of treatments, 1 month apart for the most part. They could be as close as one week apart. And they all require maintenance of a visit about once a year. The treatments can range from 10 to 30 minutes, and they are generally painless. The indications for the use of energy-based devices include vaginal wall tightening and thickening, the remission of painful intercourse by increasing blood flow, and with that increase in blood flow, it improves the glycogen content in the in the vaginal mucosa and improved natural lubrication, and pH, improving even the risk of recurrent infection, vaginal wall remodeling, and again, anti-inflammatory, less infections, and urinary incontinence improvement. The labia, and with treating with the laser, can have an improved incoloration, so whitening, wrinkle reduction, and increased elasticity. There was a survey called the Viva survey that was done that evaluated the impact of vaginal dryness in women. And 80% stated it negatively impacted their lives. 75% reported negative consequences on their sex lives. And 25% reported that it lowered their overall quality of life. 68% reported them feeling less sexual. 26% reported negative effect on self-esteem. 36% that it makes them feel old. 33% reported a negative consequence in the marriage and in their relationship. And this is extremely important to keep in mind. These are areas that need to be addressed, often disregarded, and it's an entire realm of ability to take care of our patients in a positive way. So this is an area that really needs to be focused on. And when you look at the effectiveness of what has been available, surgery will always have a place and it will be the strongest in success, but the energy-based devices come in at a close second when it comes to effectiveness and significantly less invasive. So keep these procedures in mind, and I encourage you to jump in and get involved. So typically what these lasers are doing is causing a micro injury of the wall of the vaginal mucosa. The lasers can be ablative or non-ablative, but what they are doing is all heating the tissue to cause a change in the collagen, which the body's response is to jump in, repair, and create new collagen. And there are several clinical trials that have been performed and many more to come. The FDA once again had cracked down on energy-based devices, saying that they could not use the word vaginal rejuvenation in the advertising, and that is understood. However, the efficacy has needed to be proven. The FDA's issue there is that they want a study with a placebo arm, and with devices, it's referred to as a sham arm of the study, where it's a double-blind prospective study using a sham arm as well. So those are the type of studies we are hoping for and looking forward to. HIFEM is high intensity focused electromagnetic energy that's been used for the past 3-4 years in this area. And there are several devices now that use electromagnetic energy, only one that is high intensity focused electromagnetic energy. And what it does is it causes super maximal contractions of every muscle fiber in the pelvic floor. And in doing so, strengthens, retrains, and rebuilds the pelvic floor musculature. So rather than treating the full length of the vaginal tissues like our other energy-based devices do, HIFEM treats the pelvic floor musculature. So it's taking a different approach. And when combined with the other devices, it's a incredible additive and improves not only urinary incontinence, but also sexual function. The study that was just completed in the United States was a year study following women who had not only urinary incontinence, but also sexual dysfunction. And with that, we saw a 75% improvement in urinary incontinence and a 50% improvement in sexual function. Hormones also come into play in this field. And as we know, hormones are the chemical messengers of our endocrine system, and they work in a lock and key fashion with the feedback loops that drove us all crazy in medical school, but they play a huge role in continued aging. And what we want to understand is, do we age because we lose our hormones, or do we lose our hormones because we age? And we prefer to focus on the latter. Do we age because we lose our hormones? And taking that premise, if we improve our hormonal milieu and optimize hormonal status, we can age less. Testosterone is present in both men and women. It's obviously present in large amounts in men and just small amounts in women. Men aged 30 to 70 will lose 1 to 3% production per year. And women aged 20 to 40 lose up to 50% per year. Menopause, there are 3,500 women entering menopause daily in the United States, and the symptoms may begin up to 15 years earlier. Most women are affected in more ways than they realize. Women minimize these issues. Actually, a lot of women are not sure what's happening to them, and a lot of the changes are emotional at the very beginning of the change, and they feel mood swings and they feel overwhelmingly stressed. And then the hot flashes and night sweats and poor sleep may begin, and then at that point, they may begin to realize that this is their menopause beginning. So estrogen affects both men and women, but more in women than in men, and it controls many functions of our body, over 400 functions, and is mainly responsible for hot flashes and maintenance of bone density and the texture and tone of skin, but also plays a huge role in our dopamine and serotonin levels. When it comes to the prevalence of vasomotor symptoms, the hot flashes and night sweats, what's interesting is that 10% of women will have these symptoms throughout their reproductive years, but significantly predominant in the transitional years from the close proximity to the final menstrual period, where 65% of women will be experiencing these symptoms. And within that year or two following their final menstrual period, 50%, and minimizing, but still 10 to 15% of women throughout the rest of their lives will have these symptoms. And they have an impact, again, on quality of life. So thus far, the management of these types of symptoms is to treat with changes in lifestyle, making the room cooler, fans, not smoking, recommending to not drink alcohol because that can be a trigger. using dietary supplements, and that can be of help, and prescription remedies such as going for the cause or going to try to treat the symptoms. So when prescriptions are used that are hormones, they are going to treat the cause, so the lack of estrogen and progesterone and testosterone, and non-hormonal would be antidepressants, anticonvulsants, blood pressure medications. And they are all available, and women need some form of relief. So there can be synthetic forms of hormones that come in pills, patches, and shots, or bioidentical. And bioidentical means identical to what our body makes, but plant derived, so found in nature. And it can come in the forms of pills, patches, creams, gels, and pellets. There are also wonderful articles showing the safety and efficacy of estrogen and testosterone in postmenopausal women with breast cancer. So the risk of breast cancer with the use of synthetic testosterone has been documented. However, non-oral testosterone that's bioidentical does not increase the risk of breast cancer. So coming down to the significance of all of these procedures, as well as bioidentical hormone therapy, the growth in your practice and having patients come in for these procedures have a direct influence on your revenue. And women need these treatments and deserve to have qualified physicians providing this type of care. This, again, is a area in medicine that has been greatly underserved. Now, in the United States, the medical spa industry is one of the fastest growing areas, and it has grown 20% year after year since 2013. And this is a way of supplementing income, but still practicing an extremely relevant and important area of medicine. So 4,200 medical spas in the United States, generating over $3.7 billion in revenue. In 2017, the American Medical Spa Association reported highlights of 70% of the medical spa visits are repeat patients. So there's a continuity, and it just keeps building. In 2021, do you know what we have? We have the Zoom boom. The Zoom boom is the rush to spas that for patients who can't stand looking at themselves on Zoom. They don't like the way their asymmetry looks. You know, my face is crooked. I'm trying to fix it. You know, I stand this way. And so patients not only are becoming more self-conscious of the way they look because of having to spend a year on Zoom, they are more conscious of body contouring and all of these confidence issues that have come to the surface because of the isolation through the COVID pandemic. So it's no better time to jump on board into this realm of intimate health. So here are more references if you would like. And I am open for discussion. Thank you.
Wonderful presentation as usual, Dr. Carolyn.
Thank you.
We'll have some of the questions. Can you stop the screen sharing?
Yes.
Perfect. So let's begin with the first question. So, okay, we have one question from Dr. Doa Saleh. She have written, Doa Saleh is a gynecologist and aesthetic gynecologist from Egypt. So, G-spot amplification, results and outcome, and the threads for stress incontinence. It's not in a question form. I think she looks some insight, some comments from that topic. G-spot amplification, what's your comment? Result and
Oh, G-spot amplification, is that what you say?
Yes.
Okay. Well, basically, I only use PRP, and I would be happy to use exosomes if I were permitted to in the United States. When it comes to other products in this area, I warn of complications with stricture and nodular formation. Personally, I stay away from HA in the G-spot zone. I don't mind using any PRP or PRF. That's all fabulous. But I would stick to autologous products, and I'm pretty strong on that. I tend to be relatively conservative, but I warn of the bonding agents that are used to make the HA more complex that never go out of the body. They're there forever. And we have seen strictures, especially, if you use calcium hydroxyapatite, I would definitely warn not to put that periurethral. I hope that answers that question.
Yeah. Then she have also written about threads for stress incontinence.
Okay. There are some very interesting procedures that are being offered. I have not jumped into the thread world. I'm a little bit, again, relatively conservative. I did see in the past few months a procedure that I find exciting. There's a procedure that I think it was a physician from South America doing a procedure where the threads are put on either side of the urethra in the vaginal wall, and a few, maybe 3 threads on each side, nothing overwhelmingly complicated, and acts sort of like a sling. And that looked promising, but you have to be very, very careful about some of the anatomy in the area. So, but I think that it holds promise. I just not a huge fan of threads.
Yeah, definitely. Because even last year we heard from Dr. Özgür Lelek from Turkey. So hinted on threads as well for the stress incontinence. Then
yes.
So one question we have from Dr. Mayuri. Good evening, ma'am. I have a patient who has received 3 sessions of Femilift CO2 and PRP for vaginal rejuvenation and having SUI, stress urinary incontinence. But she never found a significant difference. Moreover, she has started complaining of increase in urine incontinence within 4 months of last session. What should I offer her now? Any possible cause for it?
What I would offer someone like that is I would measure her muscle strength, and I would take a new approach and go for the muscles. So I would encourage the, I'm sorry for the dog. Grace, come here. Shh. Sorry. I would encourage the muscle treatment, like HiFem technology, and take that type of approach. And if not, surgery. There's still a place for surgery in some patients.
Good. Then we have another question from Dr. Kritika Tulani. Any use of such modalities in erectile dysfunction?
Erectile dysfunction, absolutely. I was just focusing on women today, but there's 100% efficacy. High fem is also used for erectile dysfunction. Some studies out of Europe are showing efficacy. It also works for stress incontinence in men. When it comes to PRP and exosomes, there's fantastic evidence of success. There's a study out of Greece that showed the efficacy of PRP into the corpus cavernosus and improvement in ED with the PRP as well. There are tons of anecdotal results, and I've had incredible success with patients with prostatectomies having returned to sexual function.
Of course, many of the publications, even in combination with shockwave, platelet-rich plasma alone,
Yes.
and many of.
Yes, shockwave is a great addition. Yes, matter of fact, another version of this same talk has the shockwave in there too. Couple of slides. So that's a greatly exciting area, especially for erectile dysfunction, but also in women. So wait for that. We're going to have studies in women very shortly.
Then the same doctor have a cost of Mcella chair. So it's in India.
What's the cost?
Of Mcella chair.
Well, that depends on your country and your representatives and a whole bunch of different aspects. So there is no one price.
It varies.
Yeah, it varies per country.
Then we have another question. Its name is not written. How can you throw some light on solid state laser?
Yes, so that's an extremely exciting area. It's just come to the United States. As a matter of fact, I live in New York and New Jersey. I'm flying to Dallas tomorrow, and I will be seeing the first solid state laser that has been approved for the United States. So I'm very excited about that. So I think that it's going to play a great role. It's quick, it's effective, and non-ablative. So I think that it's now another tool that we will have at our fingertips.
Role of pharma. It's again the same question. Role of pharmaceutical drugs in decreased libido. It's many.
Okay, so there are two pharmaceutical drugs available in the United States. There's Vyleesi and Addy, A-D-D-Y. Addy is the little pink pill, coined to be analogous to the purple pill for men, which is Viagra, but they work completely differently. Viagra increases blood flow to the penis, and the Addy works in the central nervous system in the brain to improve libido. However, it has associated with it an extremely high risk of hypotension, drop of our blood pressure. And if used in conjunction with alcohol, there's a increased severity of hypotension, and there have been reported deaths. So I do not prescribe that medication. I never have. I don't find a significant reason to use it, especially if women can't tolerate penetrating intercourse because of other anatomical issues. So why make a woman desire intimacy when she cannot tolerate intimacy? So for me, it just hasn't been of any great addition to my armamentarium. Vyleesi, on the other hand, is a peptide. Peptides are a very exciting area of medicine. Unfortunately, in the United States, once again, the FDA has strictly restricted their use and availability, but Vyleesi is a FDA-approved product that is made by the pharmaceutical industry and is now available as an injectable for women to use, and they inject themselves approximately 4 hours prior to desire of being intimate, and it has been shown to improve that experience for women. The issue and the side effect of Vyleesi is a side effect of nausea. So very often it's given in conjunction with the Zofran or an antiemetic.
One question we have from someone, it's presently which vaginal procedure using IVDs are approved by FDA?
What are, okay, so the devices are approved by the FDA for gynecological use to improve tissue, as with collagen. That's what they're FDA approved for. None of them specifically say that they are approved for intravaginal use. But if you look at the word gynecological, that includes the vagina. So they are not specifically verbally written in the FDA approval for intravaginal use, but they are approved for gynecological use for the improvement in texture, tone, and quality of collagen in the tissues. So that's what we have.
And even in 2021 paper have published already, there was a very good white paper on the consensus on that, and 18 points already considered by the FDA. So and ultimately FDA gives the clearance for the medical devices usage in between.
Oh, yes. Oh, yes.
Patient and their respective doctor through the informed consent. So
that's right.
This is what the role of the FDA. Then do lasers have any role to play in vaginismus? If yes, how?
Do what have any?
Lasers have any role to play in vaginismus?
Lasers. Not lasers. I don't use lasers for vaginismus. I do use HiFem for vaginismus, and I do use Botox for vaginismus. Those are the two main uses, but I also will say that focused intense shockwave therapy will be very useful for vaginismus as well. So there's a great study out of Israel that shows the efficacy of shockwave, and it's a 15-minute procedure used in 3 areas of the introitus, externally placed at 8 and 7 o'clock and 4 and 5 o'clock, and smack in the middle of the introitus, using the device for 5 minutes in each location, and it just hold it there. There's no movement involved, and it takes 15 minutes, and with use of that 6 times, there's great improvement in vaginismus. So those are my 3 main go-tos for the treatment of vaginismus.
Even we have published recently 2 papers with that's a very old study with Dr. Suleiman from Turkey and Didam. A study of 540 patients. It's already in the ResearchGate and other publication sites. So this year we have published the data of 540 patients. So they can find out from there. So more. Then another question from Dr. Anjali. It's your expert comment on consent performa for laser or thermal procedure on the vagina.
I'm not sure I understand. What is my consent?
Comments on consent proforma, like she's asking for some of the comments on the which kind of consent it should be, the informed consent for laser or any thermal procedure. She's asking for the format for the informed consent.
Yes. So your informed consent has to say that it is a procedure that does not have specific FDA approval for intravaginal use. However, it does have approval for the treatment of gynecological tissue, and it will have everything has risks, and those risks include, and you itemize risk of scarring, burning. It's a laser, so bleeding, urinary tract infection, and you just even come up with absolutely anything that possibly could occur, even if it's never been reported. Such things as, severe dyspareunia or anything like that. So you just put everything in there that you think could possibly happen, and that's the best you can do. And so, general surgery, you put patients under general anesthesia when you do a major hysterectomy, and, same kind of thing when you're at the risk of death.
Okay. Then another question is on annual cost maintenance or EBD. See, we are not taking any financial questions. It varies from clinic to the size of the hospital to the geographical locations. And it depends in which location you are, like everything depends on that. And the maintenance of EBDs is almost consumable based therapeutics. It's a per patient have their own consumables for hand pieces. So it's like almost a minimal cost involved for the maintenance. We just need some calibration once a year, like that. Then one question from Dr. Sohela Hashimesi is our fellowship colleague as well from Iran. Would you please explain more about exosome?
Exosomes are excrement of a stem cell. They are very small, non-cellular particles that are exuded by stem cells. They are typically a allogenic product, meaning that they are not from the same patient. However, there is something in the United States called super shot, and it is a way of extracting a patient's own exosomes from their blood, their PRP themselves, and you can do an extra step, isolate the patient's own exosomes and inject it back in at the same setting. And that's allowed by the FDA at the present time, even with the new ruling as of yesterday. So that's exciting. But once again, exosomes are small anuclear particles that come off of a stem cell that carry microRNA and messenger RNA, and with that are able to trigger the body's response to create new tissue where needed.
And it's like many development, we have seen the yesterday's things decision from the FDA. It's really like what we can say, still like there is some more like we can say some flexibility should be given on 351 especially, and 360 we have already known for amniotic membrane and all, because but the thing is consideration, fine, if allogenic high through output production cell free substances, definitely people should go through the clinical studies. So it's good.
Yes.
It's some control into the malpractices. So that's a good part, because it can be taken from the adipose. It can be derived from the mesenchymal stem cells, because it's you just need to make it cell free. Once it will be cell
That's right.
free and highly immunomodulatory, and it's a nano scale of the size. So it's highly penetrating, highly the engraftment. The objective of the using the exosome, it engraft very rapid. It reaches to the targeted sites, and it's a very clever cells basically. It knows like where to diagnose and where to engraft. This is the inherent property of the exosome. Some of the questions more they have added from Dr. Meenakshi Sabarbal. What is your experience with hyphen for stress and urge incontinence?
the beauty of HiFem is that it is effective against all forms of incontinence, stress, urge, and mixed and frequency in both men and women. That's the most incredible aspect of HiFem. So in my opinion, the prerequisite for sitting on the HiFem chair is, do you have a pelvis? And then anyone with a pelvis should sit on the chair. And it is extremely effective, 75% effective for stress and for urge incontinence. I was giving this similar lecture in San Francisco, and there's this gentleman in the audience nodding his head, and I thought his head was going to fall off. He was nodding. He was so excited. And after my talk, he came up to me and he said, my wife has the chair. His wife is the physician. And he said, I sat on it. I used to wake up 5 times a night to use the restroom. After sitting on the chair, I sleep through the night. Sleep is so important, and it has so many ramifications on the rest of our health. So being able to sleep through the night is unbelievable. And that is a overactive bladder or urge incontinence, and it's treated by the chair. I hope that answered the question.
Now we don't have any questions from anything. So, Dr. Nidhi, yeah. So thank you for today, Dr. Carolyn. Now I'm handovering to our colleague, Dr. Nidhi Khurana. Probably she have some of the questions she collected might from the Facebook or something.
Okay.
Yes. So, Dr. Carolyn, since this is open to everybody from medical background or non-medical background, so I just wanted to ask you some very general questions about your field and about yourself. And let me start by asking, what encouraged you to build your career in cosmetic gynecology?
The need. And basically, it is the experience of sitting on my little stool in my office, speaking to my patients and hearing what they had to say. So on a daily basis, I would have women say that they were no longer interested or no longer intimate with their partner. And this began most prominently mid-40s and carried on through the rest of their lives. And mid-40s, darn it, I'm almost 60. And to think of not being intimate all that time is crazy. I think it's a waste of a relationship, because that bond that happens with a intimate partner should never go. That's glue that keeps the relationship going. And it's a ripple effect. When someone has a healthy, intimate life, they have a bounce in their step. They go and enter the world with a much better attitude. Let's face it. So then when you don't have that, there's a sadness, there's a lacking, there's a loss of confidence that goes on. So when I heard that day in and day out from my patients saying that they no longer did, oh, I don't do that anymore, it hurts, or I'm not interested. No, lack of interest, lack of libido, even if it's not uncomfortable, they're just not as interested, comes from a lack of testosterone. And it can come from a lack of sensation. So it has to be explored, it should be addressed, and it should be fixed so that they can return to a much more rewarding, healthy lifestyle. And it affects even their children. When a couple is happy as an intimate unit, everyone knows it. The children see that mommy and daddy are connected. There's a bond that occurs. When that's broken, the children know it too. And they feel that stress and it affects even their life. So an intimate relationship is absolutely integral to everything else in our lives.
Well,
And that's why I focus on it.
great. That was an amazing answer, actually, the need. And so I don't know how it is in the US, but at least in India, women are not very comfortable in sharing such issues, even with the gynaes, until and unless the questions, I think, come from the gynaes themselves. So
Exactly.
yeah. So like, how do you think can the medical practitioners help their patients, and how have you done throughout your journey?
Very good question. Number one, as a provider, you can't be embarrassed to ask. You got to get over your own shame and realize that, number one, I think the majority of gynaes who don't ask the question because they don't think they have an answer. That's number one. They don't realize that all of these procedures exist and are available and they work. So, number one, as a doctor, you have to understand that there are solutions. Number two, you can't be afraid to ask the question. I ask every woman who walks in, intercourse is okay? Is sex okay? How are things in the bedroom? It depends on who I'm speaking to, the approach I take, but everyone gets asked. It doesn't matter if they're 15, 16. I ask them too, because they may be exploring things. They may be trying to love themselves. And if that's something, it can be addressed and assisted and made sure it's safe, et cetera, et cetera.
Yeah, because that is very much required. Otherwise, the patient themselves, it's very, very difficult for them to, because first of all, they don't realize that they have a problem which has a solution out there. So,
Yes.
yeah, so it is very much important on the medical practitioner part. And yes, you wanted to say
I
something?
want to say one more
Yeah,
thing.
please.
Another way that's evolved is making a very, very simple questionnaire. It cannot be 20 questions. It can be 4, 5 questions maximum. And not overwhelmingly invasive. So when the patient comes into your practice, especially as a gynecologist, you have them answer, are they having issues with losing urine? Are they having issues with intimacy? Are they having pain with intercourse? And is this something you would like to speak to the doctor about? Yes, no questions. Yes, no, yes, no, yes, no. No big complicated answers. And as the physician, you can glance at it and say, this is something I better address. But if it's all no, 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 okay, you don't have to waste your time. I still ask the question verbally, but if everything's great. All right, all done.
Right. Okay. Before I move forward with one of my questions, I would like to ask one that are coming in the chat box too. So there's this question: can laser devices be used in recurrent vaginal infection?
Yes. Yes, it's the beauty is that we have seen an enormous improvement in recurrent vaginal infections by improving pH. And that I did also see a question about carboxy therapy. Carboxy therapy is fabulous to use as well. It's just somewhat invasive with the needles giving the carboxy. And there is a product in the United States that is a gel that the patient can use at home on their own that recreates the carboxy sensation. So it actually works like carboxy, but it's a topical gel that's applied into the vagina. And it works very, very nicely. And Dr. Red Allenside and myself, we use it in conjunction with our our laser procedures and have the patient go home with it and use it for 5 nights following a procedure. And then they can use it once a month for maintenance of the tissues.
Great. I think there's another comments that are required from you on the use of Botox in SUI.
Stress urinary incontinence.
Yes.
I do not use Botox. That would be a mistake. For stress urinary incontinence, it would relax the urethra and cause increased loss. It can be used for overactive bladder, intravesical. You have to use a cystoscope. I'm not a urologist and I don't do that. I would have them see a urologist for that procedure, but that's for overactive bladder in extreme cases, but it can be very effective, but has to be done transurethral. Yeah.
Right. Now my question to you is, since all this is, still gaining momentum, the cosmetic gynecology field, and so are these courses like the one launched by IASRM, Fellowship in Regenerative Medicine, Stem Cells, or Fellowship in Cosmetic Gynecology, what kind of relevance do these courses hold for the medical practitioners who wish to, pursue this in their career?
I think no matter what you do in medicine, you have to have appropriate training and certification. And it's critical that you get a very respectable, excellent training as is offered here and in other very reputable courses that are found worldwide. But I think that it's critical, no matter what we do, that you get appropriate training and understanding. This is complicated. I find that in the United States, gynecologists are petrified to get involved in this space because they don't understand the technology. They're not accustomed to using lasers except to burn off warts. And they are not accustomed to radio frequency. They're not accustomed to doing injectable or regenerative procedures. So they are petrified to jump into the space because of fear of technology. Yet plastic surgeons and dermatologists in the United States are very comfortable with these procedures. They are absolutely petrified of the anatomy. The vagina is frightening. So they're yes. So I, as a faculty of the different types of associations in the United States, try to bridge that gap. But you have to be familiar with both anatomy and technology, and it takes appropriate training.
Right. And I think with this, Dr. Prabhu, do you have any more questions by yourself or
only
the
one
audience?
question, Dr. Caroline, one question they have given. For recurrent infection, how many sessions to be done?
For what kind of infection?
Recurrent infection.
Oh, for recurrent infection, same thing. Once a month for 3 visits for the laser treatments. And then maintenance about once a year. Everyone's different. Sometimes it may have to be repeated 6 to 9 months.
Dr. Caroline, before summarizing everything, I would like to ask one question I have, because most of the time, because when when everyone asks, because you are also an advisory board, and in the group you have seen many times the discussion has started, like being a startup, if any gynecologist starting the procedure, the young gynecologist, I'm talking like the young practitioner are starting the procedure. Okay. The confusion is, which device should we go? Laser, CO2, RBM, go for the radio frequency, go for the
Eeny, meeny, miny, mo.
So,
Okay, when it comes to
devices,
devices, you need to know what you can afford and what goal you have in mind. Number one, lasers will always be the gold standard of technology. If you want the most effective, quickest type of energy-based device, it's going to be a laser. The lasers are going to be more expensive. Variables with lasers are, in my opinion, you want to have something that will not limit the number of patients you can see in a day and the time it takes to go from patient to patient. I encourage something that has, honestly, a disposable and a consumable, meaning a sheath over the probe. And that's individually used per patient. The reason I encourage that is because I don't run my autoclave when my patients are in the office. It makes noise, it smells, and it's time consuming. So it would limit the number of patients I can treat in a day if I have to autoclave the hand pieces. And the most I would want to buy would be 3 or 4. They're highly expensive. So with a disposable plastic probe over the sheath, I can use as many patients as it takes to get them dressed and undressed and in and out of the room for a day. So that is a much more effective way, in my opinion, for getting the patient seen. Should a laser be way, way out of the cost bracket, then the radio frequency devices would come in handy as second.
Thank you so much, Dr. Carolyn, for this beautiful elaboration.
Thank you.
Yeah, Dr. Nidhi. Yeah.
Yes. So thank you so much, Dr. Caroline, for having us as your audience today, because the lecture was amazing. And
thank you.
the way you've answered all the questions is really, really great.
The device from A to Z.
Yes, absolutely. And I take this opportunity on behalf of the entire team of STEMGen and IASRM to present this certificate of appreciation to you.
Oh, thank you.
Yes. And I request Saloni to put it up on the screen so that everybody can see it. Okay. Yes.
Thank you.
Right. And thank you so much for sharing your wisdom, your journey, and your knowledge with all of us. We are so glad to have you with us today, and we look forward to keep having you, for our future endeavors and lectures and the sessions that we arrange for our audience.
Thank you so much. My pleasure always. And please, everybody, jump in, 2 feet, jump. Woo!
Yes, exactly. So do not be scared, learn and move forward. And so thank you so much once again. I thank the audience, whoever is there with us on this platform today, and everybody who is watching us live on Facebook. We will keep conducting these sessions on HealthTAPE. We have our next session on Dr. Prabhu, if you can just
it's on a 12th of June.
12th June.
Dr. Red
Yes,
M.
right. So the next session is on the 12th June, and I hope to see all of you again in that session. And till then, everybody, and see you in the next episode of HealthTAPE on 12th June. Bye-bye, everyone.
Thank you so much. Thank you.
Thank
And
you.
we are thanking each audience, because without audience, this kind of discussion is never possible. So kindly be participating actively. We are really, it's a really pleasure to have you everyone on this platform, and welcome you all for the future events. And I'm extremely thankful, even in this situation, Dr. Caroline, you are not even supposed to sit like for long hours. You have joined us. It's really kind. You are so kind to me. It's a huge obligation. Thank you. It's a pleasure to have you. Thank you.
Thank you so much.
Thank you.
Bye-bye
Thank you
now.
so much.
Thank
Bye-bye.
you. Bye.